Good morning. So good morning. Thanks for coming. Welcome to the Yale Interventional Radiology Grand Round. It is such a pleasure today to have Dr. Fuchs, Charlie Fuchs, who is not only the director of our Yale Cancer Center and the physician-in-chief for the Smilow Cancer Hospital, also the Sackler professor of medicine in medical oncology for Yale School of Medicine. He's a renowned international leader in GI cancer. As a just quick background, he doesn't need an introduction, but he spent most of his career and the training in Boston. Other than his undergrad at the UPenn, he went to Harvard Medical School. All the training, both the clinical and the research in oncology, were at the Brigham and the Dana-Farber. He started his career, the academic career, at the Dana, and very quickly promoted to a full professor at the Harvard Medical School. In fact, he assumed the Robert Judith Hale chair in pancreatic cancer at the Dana-Farber Institute, and also the chief of GI oncology at the Dana-Farber before he saw the light, and he came to us 2 years ago as the head of our Yale Cancer Center. So, as I say, he's the world leader in the GI cancer. In particularly, he has so many accomplishments with the Sentinel studies, trials, over 550 peer-reviewed scientific journal articles, and so many of the works that he has done now is a standard practice in GI oncology. So it's our distinct pleasure to have Dr. Fuchs. He will discuss big data approaches to advance colorectal cancer prevention, treatment, and the biology for us. Thank you so much.
Yeah, thank you. Thank you. Thank you. Well, I really appreciate the invitation to join you. I've in my now roughly 2.5 years at Yale and Smilow, it's really been my privilege to meet so many individuals working across many disciplines that are committed to advancing the mission of the Cancer Center. And clearly, interventional radiology, diagnostic radiology has been so critical for success. As a matter of fact, depending on when you start the clock, either late this fall or early next year, we will be celebrating the 10th anniversary of the opening of Smilow Cancer Hospital, which in the history, and really the esteemed history of this cancer center, is certainly a landmark event, because as probably many of you know, when that 15-story building was open, initially empty, it has witnessed an extraordinary growth of a world-class clinical operation. Last year, for instance, just as one measure, Smilow saw 233,000 office visits. I'm not counting anything else done. I think as a measure, which was really probably a 4- to 5-fold increase in the volume over the decade, and a 4-fold increase in clinical trials. And candidly, all of you have been, I think, so critical for advancing that mission to bring cancer care, expert cancer care, to more and more patients across the state, now across the Northeast, and expanding our ability to provide highly impactful research. So, really is a privilege to speak with you. My career has spanned sort of a gamut of research, which includes some basic research in the lab, clinical trials, and having the privilege of being involved in a few approvals for drugs for GI cancer, and at the same time working as an epidemiologist, but really in the context of trying to use that approach to research in a way that informs clinical care. So what I'm actually going to share with you, let's say over the next 45 or 50 minutes, is work in that domain. But hopefully in the process, what I can share with you is the ability, I think, when sort of leveraging data sets to really better understand how we can approach primary prevention, secondary prevention, as well as how we can better improve the outcome for patients, and maybe in the process learn something about the biology of colorectal cancer. So these are my disclosures. I want to make sure I do that at the opening. Let me just share with you the data sets that I've used throughout my career. You know, what the ideal thing, I think, when you're trying to look at both prevention and outcome is to get very large, unselected populations of individuals, of healthy individuals, who then you can, when they develop cancer, you can study them, which is not easy to do, and certainly was a challenge for me as I anticipated wanting to do this more than 20 years ago. But I was able to meet the folks who ran these studies, which you may have heard of. The Nurses' Health Study was established in 1976 to look at risk factors for heart disease in women. And specifically, its design was they recruited 121,700 female registered nurses residing across the US who in 1976 completed a 20-page questionnaire about their lifestyle, their medical history, their diet, their family history, among other things. And they actually repeated those questionnaires every 2 years. The study actually continues today. I just ran out of room on my slide, so it continues to follow these people every 2 years. But in addition, they provided over time blood samples. They provided medical records. And when I came along, I said, you know, you're sitting on a gold mine not only to understand heart disease, but you can actually study cancer because, you know, you have statistical power to do that. And was able to convince them that when individuals were diagnosed with GI cancers, that the tumor blocks would be sent to a laboratory that I set up, which over the years would use whatever technologies you had available to do high-scale molecular annotation of tumors. And that's really the resource that I've used. The Health Professionals Follow-up Study was a similarly designed cohort of men established a decade later, but with the exact same intent. There's a number of other similar studies across the US that have been conducted that I've been able to cajole to study GI cancer. So in fact, over time, I had the privilege of accessing about 350,000 individuals' data who, again, had given permission to study them in terms of risk factors for cancer, and then obviously following them if they developed cancer. So as I mentioned, the questionnaire that the nurses were given included a 131-item food frequency questionnaire with the idea of understanding what elements of diet would predict their risk of colon cancer. Now, to be clear, I know there's a lot of cynicism about this type of research, but I can tell you the people that work in this cohort are really very rigorous nutritional epidemiologists who developed this questionnaire, which is quite lengthy, by then correlating it with blood assays of various nutrients, of diet records conducted independently, and really did a great job of coming up with a fairly validated assessment of long-term dietary consumption. And really wanted to understand what elements of diet might predict. Now, again, these questions were asked when they were healthy. But when you're studying 250,000 people, you have a fair amount of statistical power to study this over time. And so one of the questions, there's 6 questions on red meat consumption. One of them, among others, is how much beef, pork, or lamb you eat as a main dish. And as you can see, with increasing consumption of beef, pork, or lamb, there is an increasing risk of developing colon cancer over the follow-up period, which such that the nurses who said they had beef, pork, or lamb once a day or more were almost 3 times more likely to develop colon cancer. Now, you know, there's strength in numbers, and there have now been a litany of studies, all of which show that people who consume high amounts of red meat are at a significantly higher risk of colon cancer, such that various organizations, AICR, all of them have now included red meat as a risk factor, established risk factor for colon cancer. As well, I think we've increasingly realized the role of obesity in cancer risk. And early on, there was, frankly, considerable biologic data that energy balance pathways, excess energy, drives colon cancer in various model systems. So we wanted to measure adiposity. This is in the men. And by the way, you can measure adiposity in a variety of ways. Body mass index, which is a function of weight and height. Another is central adiposity, which you basically do is with a tape measure, you do waist to hip ratio. And in the questionnaire is a tape measure. And so we actually asked the respondents, the participants, to measure their waist to hip ratio. Now, one thing you may wonder is are they being truthful and or accurate in both their height and weight and waist to hip ratio. And this is the rigor of the cohort. They actually sent research staff to the homes of randomly selected participants across the US and knocked on their door and had them step on a scale and measured their waist to hip ratios. And the correlation between what they found and what they reported was 0.99. So it looked like they were being honest. And with that increasing waist hip ratio, increasing central adiposity, there was an increasing risk of polyps, large adenomas, ones greater than 1 centimeter or greater in the follow-up period, as well as an increase of colorectal cancer, where you can see almost a 3.5-fold increase with increasing adiposity. And today, obesity is an established risk factor for colon cancer. Beyond that, related to adiposity in Western populations is the concept, the phenomenon of sedentary lifestyle. There is a 1-page questionnaire on leisure time activity, litany of activities, be it running, jogging, walking, bicycling, golf, tennis, swimming. And each of those activities has a metabolic equivalent score. And as well, they're asked, how often do you do these activities, each of them? And for how long do you do them on average? And what you can do is calculate a met hours per week score. Again, that was independently validated and then looked at with respect to the follow-up in the cohort. And those men, this is the male cohort, who were in the highest category of physical activity, who were exercising roughly 3 times a week, had about a 50% reduction in their risk of developing colon cancer over the follow-up period. Since that time, about 52 studies have found that regular physical activity substantially reduces the risk of colon cancer. And as a result, that too is now considered an established risk factor for the disease. So beyond that, beyond trying to convince healthy people to eat right and exercise, it's a lot easier to convince people of taking some supplement or pill. And you're probably aware there has been an abundant amount of preclinical data suggesting that aspirin and selective COX-2 inhibitors, cyclooxygenase 2 inhibitors, can impair the growth of colon cancer both in vitro and in vivo. As I mentioned, the Nurses' Health Study was established to look at heart disease. Needless to say, as a consequence, they got detailed information on aspirin use. I mean, incredibly detailed information, because that was the test. Does it work in women? We then leveraged that data to look specifically at the outcome of colon cancer over a 20-year follow-up period. And what we looked at in this case was the number of adult 325 milligram tablets or equivalent thereof. Why? Because in the lab, in contrast to heart disease, to really inhibit cyclooxygenase 2, there is a fairly strong dose effect. More is better in terms of inhibiting colon cancer growth in the lab. So we wanted to look at that dose response in the nurses by their reports of aspirin use over time, and found that with increasing number of adult tablets, there is a reduced risk of cancer, such that the nurses who said they were taking more than 14 tablets per week had a 32% reduction risk. Now you might say that's a lot of aspirin, and almost certainly a likely invitation to not only address colon cancer risk, but actually see your gastroenterologist for GI bleed. But we asked them why they were taking aspirin at the time, And it was not because of heart disease, because at the time there really wasn't a lot of information about that in women. The two principal reasons they were taking that much aspirin were musculoskeletal complaints and headaches. But regardless of the reason, we did see a dose response. And since that time, there have been a litany of trials, level 1 evidence. So the British doctors' aspirin study randomized individuals to aspirin or placebo, found a 30% reduction in risk for colon cancer. A number of adenoma prevention trials using either aspirin or COX-2 inhibitors, Celebrex, show a reduction in risk in adenomas, such that the U.S. Preventive Task Force have now established that aspirin is a chemopreventive agent for colorectal cancer. So I don't want to get into more of this other than to say that, over the years, I think there has been a great deal of evidence saying that these things are really drivers of colon cancer risk in Western populations. And some of them associated with decreased risk, such as exercise, aspirin, calcium intake, among others. And some associated with an increased risk, such as obesity, red meat, a high glycemic load diet. And beyond their other effects on cancer risk, alcohol and smoking have been found to also increase the risk of colon cancer. So, that's sort of studies of individual factors in isolation. One thing that we wanted to do, realizing that you want to consider clinically a recommendation to healthy populations, was to look at a group of an approach in aggregate. And so we contemplated 6 things that one could do to be more healthy. That is, avoid obesity, exercise about twice a week, take a daily multivitamin, not consume more than 1 alcoholic beverage per day, up to 1 a day, not smoking, and not having red meat as a main dish more than twice per week. And what we thought was this was a pretty achievable approach. It's not draconian. We weren't looking to see, well, what would happen if you just eat hay. We really just wanted to see something that could be done. Now, we looked at this in the male cohort. So obviously a group of well-educated male health professionals. And we wanted to see what proportion could do this. Care to guess what proportion could do this approach to lifestyle? 15%? Yeah. 3%, that's right. I guess it isn't easy. But among those brave souls who were able to do it over the follow-up period, they actually had a 71% reduction in their subsequent risk of getting colon cancer during the follow-up period. And I would posit to you that diet and lifestyle is probably the major driver of colon cancer risk in Western populations, which is not a surprise, because if you're aware of this, colon cancer has historically been unheard of in underdeveloped parts of the world. It doesn't exist. It does now because they've been acclimating to Western approaches to diet and lifestyle. But prior to that, it just didn't exist. And there's a 40-fold difference in incidence between those regions of the world. And I would suggest to you it's because this is such a driver. But what's really compelling is that primary prevention would likely work, not only obviously for colon cancer, but a variety of ailments that we treat among Americans, including heart disease. So something we think is relevant as we consider approaches to prevention. But beyond prevention, as a practicing medical oncologist who sees patients with GI cancer, I realized that I wanted to try to look at this in a population that was really focused on it. Because in fact, if you're probably aware, the people who pay attention to these data are rarely healthy people, because healthy people, we all think we're indestructible. We can eat, drink anything. But patients are very focused on this. As a matter of fact, studies show that about 75% of newly diagnosed cancer patients believe that there is a diet, lifestyle, or supplement that will improve their chances of cure. 75% of patients believe that. And in fact, in some of those studies, you'll find that not only do they believe that it has an effect, they also believe that medical practitioners do not want to share those data with them. They actually believe that we hide that. We're not willing to discuss that aspect of care with them. Now, the truth is I think if we don't discuss it, it's because we don't have any data. Everything has largely been anecdotal. And certainly plenty of patients come to me and maybe to all of you about, asking about some of these supplements or other things off the web. So what we wanted to do is take that same very rigorous prospective approach, and in this case, not look at it in people who are healthy, but people who have been recently diagnosed with colon cancer. And so did this in a large US adjuvant study. CLGB 89803 started in 1999 when 1,260 stage 3 colon cancer patients who had undergone a curative resection were then entered into a trial of post-operative adjuvant chemotherapy, which at the time was asking the question of standard 6 months of 5-FU-leucovorin, a standard post-operative adjuvant chemo regimen, or a somewhat newer regimen at the time, a regimen of irinotecan 5-FU-leucovorin. So does adding irinotecan improve the success rate of adjuvant chemotherapy, realizing in stage 3 node-positive patients, the goal is cure, preventing recurrence? The bottom line on the answer to this chemo question was it's null. Adding irinotecan, CPT11, does not improve disease-free survival or does not reduce recurrence rates in post-operative stage 3 colon cancer. But why am I telling you this? Because of persistence by me and my colleagues, because I was involved with the trial, the NCI agreed to allow us to include that questionnaire that we developed for the Nurses' Health Study, at that point a 24-page questionnaire, in the trial, such that patients were asked to complete it roughly at the start of the study, and then about 6 months after they completed their adjuvant therapy. Now again, these people were cancer-free, and because they were entered into a clinical trial, they were defined cancer-free by, the surgeon submitting the op note saying, that the resection was done successfully, the path report saying that the margins are clear, a post-operative CAT scan that showed that they were disease-free, a physical exam, blood work, really a complete assessment by any clinical means available saying that there was no evidence of cancer. And moreover, they had to be healthy to get into the clinical trial. They had to have an ECOG performance status of 0 to 1. So really a pretty good population where they were well documented to be cancer-free, and where the endpoint is not whether they developed colon cancer, but did they have cancer recurrence? And again, the assessments were done before we would know who among them would ultimately have a recurrence of their cancer. One other thing I should mention is when we imposed ourselves on the people running the study in 1999, there was a great cynicism about whether patients would complete the questionnaire, because they're focused obviously on their cancer treatment, and they wouldn't necessarily want to be bothered with this. And also, this is 1999, so we didn't have the technologies for doing these things today. What we actually did is, for those of you who recall, when you would take the SATs, you get a number 2 pencil and a thing, and you black out the little circles with the answers you want. That's what we gave them. But in fact, 98% of patients actually completed the first questionnaire, and 94% completed the second. That's really an unprecedented response rate to questionnaires. I think it just reflects how committed, how interested patients are in this research. So I mentioned the benefit of physical activity. What we found was that was increasing regular physical activity, there was a diminishing risk of mortality in these patients. The most common activity in these people who are on average in the age of 60s was walking. Those patients who said after surgery they walked 6 or more hours per week had a 47% improvement in their disease-free survival. That is a reduction in their cancer recurrence or dying from their cancer. At the same time, and I should also mention, we looked at obesity and found that obese patients had a higher risk of cancer recurrence. We also included the diet questionnaire. It included about 130 items. So because we really didn't know where to start, we decided to use the answers in aggregate. And how did we do that? We basically did something called a factor analysis, sort of an unsophisticated AI approach, where you basically tell the computer, take all the responses from the dietary questions and see if you can bring them into two distinct groups based on their responses. And I will point out, if you do that with any lengthy dietary questionnaire, if you say to the computer, divide it into two groups, in a US population, you will always, and I mean always, get the same two groups, which are a group that's often referred to as a Western pattern diet, which is typically characterized by red meat, sweets, desserts, French fries, refined grains, those things that many of us enjoy eating, as opposed to what's often referred to as a prudent diet, characterized by fruits, vegetables, legumes, fish, poultry, whole grains, those things that we intuit to be healthy. Now, this is an approach that's been done for decades in nutritional epidemiology. And in fact, if you look, it's been shown that a Western pattern diet increases your risk for heart disease, for type 2 diabetes, and in fact, the risk of developing colon cancer, perhaps no surprise. But here, the question we wanted to answer, if you do this, if you look at diet after the diagnosis of colon cancer, do these patterns matter? So we looked, and when you look at an increasing prudent diet, in fact, it doesn't affect, there really was no effect on their outcome. You know, whether they were low or high in this category, it didn't matter. So, you know, for those patients who feel compelled to eat a vegan diet or eat hay or some other thing they learned about, I mean, there's no harm in that per se, but there's also no evidence that it improves the likelihood of their cure from colon cancer. But when we looked at consumption of a Western pattern diet, we found that those patients who were in the highest quintile of a Western pattern diet were 4 times more likely to have their cancer recur or die from colon cancer. And since that time, a number of studies have similarly looked at post-diagnosis diet and found a similar higher rate of recurrence in people who embrace this type of behavior. So related to this is sort of a high carb diet. So you probably know the Atkins diet, South Beach diet, all of these things have been purported as a means for weight loss. And I think the evidence is compelling that carbohydrates do drive heart disease risk, they drive risk of type 2 diabetes, and they drive the risk of obesity. And because of our data on energy balance, exercise, obesity, we wanted to look at that in this population, and we calculated their dietary glycemic load, that is, the amount of carbs they're consuming that are characterized to increase both blood sugar and insulin levels. And we found that those individuals in the highest quintile of a dietary glycemic load were actually 80% more likely to have a recurrence of their colon cancer or die from it. So, as I mentioned, a number of factors that seem to drive risk of recurrence, to our surprise. Obesity, sedentary lifestyle, a Western pattern diet, a high glycemic load diet. And one thing we want to do is to understand what is driving this. What is the mechanism? If this is true, if this observational data pans out, how would it be doing it, right? What's the biology behind it? And one contemplation was that all of these things affect your insulin resistance, right? So if you're obese, if you're sedentary, you are more likely to be resistant to insulin. That is to say, you will need more insulin to control your blood sugar. And in fact, why is that relevant? Because if you are relatively insulin resistant, you are also likely to have higher circulating levels of insulin. You're chronically hyperinsulinemic. And relevant there because if you grow colon cancer cells in the lab, often with certain lines, you actually have to add insulin to the media for them to survive. So insulin is at least important for survival and perhaps trophic for colon cancer. So is that the mechanism? So we actually wanted to look. So it's difficult to measure insulin in freestanding populations because it changes moment to moment. But C-peptide is a measure of long-term insulin secretion. And we measured that in over 373 patients with stage 1, 2, 3 colon cancer and followed them and found that increasing levels of circulating C-peptide conferred an increasing risk of dying from colon cancer among patients, such that the patients who were in the highest quartile were more than 2 times more likely to die from their colon cancer. We also, to try to sort of cross-validate it of sorts, we looked at endogenous antagonists to insulin. Now, insulin growth factor binding protein 1 is an antagonist to insulin. And so we measured that to see if the antagonist would have the opposite effect, and found that patients in the highest level of IGF-BP1 were almost 60% less likely to die from their colon cancer, suggesting perhaps that these energy balance factors of diet and lifestyle may in part be driving their effect on recurrence of colon cancer through an effect on insulin pathways. So I mentioned to you that a lot of things that we seem to be finding related to survivorship. The American Cancer Society has now decided that nutritional guidelines are something they want to put forth for patient survivors, and they've come up with this guidelines. Now, by the way, these guidelines were defined for a broad array of all patients with cancer, but what they would suggest is that we should advise patients to avoid obesity, to exercise, not a trivial amount, 150 minutes per week, to limit red meat intake, to consume fruits and vegetables, and eat whole grains as opposed to refined grains. And if you sort of follow their recommendations, you can actually find a compliance score depending on how much of this a patient does, for which 0 means they're not doing any of it, and 6 means they're doing all of it. And so we actually we applied this score to our patient population, to our cohort study of patients. And what we find is if you apply the ACS score, those individuals in the highest level of compliance, a score of 5 to 6, were actually more than 30% less likely to have a recurrence of their cancer. So albeit that guideline wasn't specifically designed on one cancer, it seems to be reasonable that the approach could, beyond our standard treatments, improve the outcome for patients. So I mentioned aspirin being beneficial in cancer risk and an accepted chemoprevention agent. What about taking aspirin after diagnosis? Again, we measured aspirin use in this patient population and found that consistent aspirin users had a 54% improvement in their disease-free survival. Again, observational data. At the same time that this trial was going on, both celecoxib or Celebrex and rofecoxib, Vioxx, were on the market. These, as you may recall, are the selective COX-2 inhibitors, cyclooxygenase 2 inhibitors, and really in the late 90s and early 2000s, they were all the rage. In fact, the sales for these things was skyrocketing for principal use of musculoskeletal complaints. Vioxx, as you know, was ultimately taken off the market because of heart disease risk, and Celebrex remains, although their sales have really plummeted. But they were abundant when the study was going on, and we asked that question among the cohort members because of our interest in aspirin. And we looked at patients who said they were taking either Celebrex or Vioxx 3 or more times per week, and found that those patients in the red had a 56% reduction in their risk of recurrence and mortality, suggesting, again, akin to the aspirin data, that this class of drugs may be helpful. So, as it's always a concern, I know, of routinely recommending this class of drugs. Can you sort of risk stratify? The cardiologists have done a great job trying to understand how you intervene, particularly in anti-inflammatories, based on circulating inflammatory factors, most notably C-reactive protein. In fact, there's now a variety of circulating cytokines that are being studied, and one that's probably better predicted than C-reactive protein for heart disease risk is soluble TNF-alpha receptor 2. And we actually looked at this in our cohorts because it had greater fidelity than C-reactive protein as a circulating assessment of global inflammation in an individual. And what we find is, and I apologize, this slide didn't project well, but in the bottom line, those in the highest quartile of this circulating inflammatory cytokine this is in patients, have a much worse survival, even adjusted for stage, higher levels of this circulating inflammatory factor predict a higher risk of cancer mortality. So can you intervene with this, with an anti-inflammatory? So we actually looked at the patients who were in the top half, above the median for this circulating inflammatory factor, to see what was the effect of aspirin. And for those individuals who were above the mean, those who did not take aspirin were more than twofold more likely to die from their colon cancer. But among those who did take aspirin after diagnosis, they were almost 50% less likely to die from the colon cancer, suggesting that maybe, akin to the cardiology literature, a means of predicting who would best benefit from this very simple intervention after surgery. We also try to understand the mechanism, and I speculate that the mechanism might be through inhibition of cyclooxygenase 2, or COX-2. Cyclooxygenase 2 is overexpressed at about 75% of adenomas and cancers. In the laboratory, expression of that overexpression predicts proliferation of the cells in vitro and in vivo. So one question we wanted to ask is, because we get the tumors in the lab, does overexpression of COX-2 in patients' tumors predict individuals who would be more likely to benefit from aspirin? So we actually did this, we addressed this question in our nurses' health study. So at the time when we did the study, about almost 1,300 nurses had been diagnosed with colon cancer. And we got their tumors, and we also asked them after diagnosis, were they taking aspirin? So just among the roughly 1,300 of them that had colon cancer, those who took aspirin after diagnosis, as you can see, had a 29% reduction in their cancer mortality. What about if we look at it by COX-2 expression? So among the 1/3 whose tumors were found to be COX-2 negative, there was no benefit to aspirin. It's not significant. I realize it's 1.22, but if you look at the confidence limits, taking aspirin didn't matter. But among those the 2/3 for whom their tumors overexpressed cyclooxygenase 2, there was a 61% improvement in mortality if they took aspirin after diagnosis, suggesting that COX-2 may be a biomarker and maybe even an understanding, a mechanism of action for why this could influence outcome. As well, we wanted to look at other pathways. So I've talked about energy balance pathways in the form of obesity and physical activity and other things. I've talked about inflammatory pathways with the idea of aspirin. These things interact because, as you know, obesity is a pro-inflammatory state, right? If you look, obese people have much higher levels of C-reactive protein, inflammatory cytokines. And so because of the interaction between energy excess and inflammation, and being the fact that they both affect the biology of colon cancer, could we look at the interaction? Now, how do we do that? There is a mutation that occurs in about 15 to 20% of colon cancers in the PI3K pathway, PIK3CA. PI3AKT is basically an energy balance pathway, intracellular energy balance pathway. If you have a mutation in PIK3CA, it drives energy in a cell. It's a mutation that occurs in a variety of cancers to drive excess energy use. So we wanted to see for those tumors that were addicted to excess energy by having a PIK3CA activating mutation, would those people be more likely to benefit from aspirin? So we actually looked at this mutation in almost 1,000 patients and found that 17% of those patients had an activating mutation in this energy balance pathway. Did they benefit more from aspirin? And what we found, by the way, this is a time to event curve. So the journal asked that it's the flip side of a Kaplan-Meier curve, right? So going up is a bad thing. It means that you had an event. And so if you look at cancer mortality specifically, comparing people this is among the people who had the mutation in their tumor, compared to people who did not take aspirin, there's a profound reduction in cancer mortality among those people who took aspirin, as well as a profound improvement in overall mortality, suggesting there really was a dramatic benefit if you had this mutation in your tumor. What surprised us was that if you did not have the mutation, there was no benefit to aspirin, which we had not anticipated. And in fact, there was a British study that followed us that found roughly the same thing. That is, aspirin only worked for the patients with a PIK3CA mutation, didn't work for those without the mutation. And so we're trying to better understand that over time, because there's a lot of other ways to activate this pathway. And so is it really a global pathway effect? As well, you know, we as we continue to look at these factors, and because of the interest in immunotherapy, we also tried to look at the interaction between aspirin and PD-L1 expression. As you know, PD-L1 is that marker that's expressed in cancer cells that can be targeted to activate the immune system. And so what's interesting is we find that the benefit of aspirin in our cohorts is really limited to people whose tumors don't express that immune target PD-L1. So if they express PD-L1, which by the way, these are the people who are eligible for the drugs pembrolizumab, nivolumab. If they do express it, there really is not a benefit to aspirin. And when we looked at that, we wondered, is it possible that could that be synergy, potentially an opportunity for synergy where you would combine a COX-2 inhibitor with a checkpoint blockade? And the reason I think it's interesting is that in parallel, in the journal Cell and now multiple journals, they find in various animal models that when you combine aspirin or a COX-2 inhibitor with a PD-1 antibody, you actually get significant synergy. And there's now actually trials going on to look whether you can enhance the effect of these drugs in patients who would otherwise be getting checkpoint inhibitors for their cancer. But I've shown you a lot of observational data. Are there interventional data for this? And this trial was a study we developed a number of years ago, CLGB 80702, which is taken 2,500 stage 3 colon cancer patients, randomized them to 2 durations of adjuvant chemotherapy, but concurrently has randomized them to 3 years of post-operative celecoxib or placebo. And the study is done, it's accrued. We're actually been waiting now for about 2 years for there to be enough events so that we can analyze the data. And it's taking, frankly, longer than we thought. So we're hoping that in the first quarter of 2020, we will have enough events to test whether post-operative celecoxib improves outcomes. So achieving what we hope is level 1 evidence for this hypothesis in standard treatment of colon cancer. And then finally, I want to touch base on the vitamins, because as you may know, the multivitamin industry in the US is a $24 billion industry, recognizing there's probably little or no evidence that taking a multivitamin in a healthy US population has much benefit. But one vitamin that we've been interested in is vitamin D. That vitamin, as you know, relevant for our bone health. And interesting because, first, that vitamin D receptors are frequently expressed on colon cancer cells, and that you can actually affect proliferation by modifying the expression of the vitamin D receptor in vitro. That vitamin D does appear to inhibit growth of colon cancer in xenograft models, in the APC mean, that is the genetically engineered models for colon cancer. And also, if you take those genetically engineered mice predisposed to colon cancer and you then knock out the vitamin D receptor, they get more tumors. So really suggesting that maybe this pathway is relevant. So we actually did some observational data in another large US cohort. This is a clinical trial of stage 4 colon cancer patients where they were testing 2 different chemotherapies, but we actually got blood samples at the onset of this trial. And we measured 25 vitamin D levels in the baseline bloods of these patients and found that the patients in the highest level of plasma vitamin D had a significant improvement in mortality, so a 35% reduction in mortality, as well as a significant improvement in progression-free survival. So observational data suggesting that patients getting treatment for stage 4 colon cancer do better if their vitamin D levels are higher. That's purely observational data. So we actually decided to proceed with a randomized trial of patients with stage 4 disease. Now, what we did was a randomized phase 2 with newly diagnosed stage 4 patients and randomized them to standard chemotherapy, FOLFOX, bevacizumab, plus a low dose of vitamin D, 400 international units per day, as opposed to the same chemotherapy plus a high dose of vitamin D, 8,000 units a day for 14 days, followed by 4,000 units every day until disease progression, with the primary endpoint of progression-free survival. And what we found was that individuals randomized to the vitamin D had a significant improvement in progression-free survival, which was about a 2-month improvement in progression-free survival, or a hazard ratio of 0.69. Now, you may say, well, that's a pretty modest, if not trivial, improvement. Except I will point out, if you're not otherwise aware, every drug that's been approved for metastatic colon cancer in the US gets approved on roughly the same magnitude of benefit in stage 4 colon cancer. And those drugs have helped. But I think this is a magnitude that you won't see any different. As a result, the NCI is in the process of advancing a phase 3 trial to potentially confirm this observation. So in sum, a number of things that reduce risk and maybe some things that improve outcome for patients, such that I think we could potentially offer people beyond our standard approaches some benefit. And then in the last 2 minutes, I just want to share with you the power of also collecting the specimens, because what we've done beyond collecting all of these data is, I say, to collect the tumors, and now we're getting an increasing ability to technologically characterize the tumors, either by genomics, by assessing the lymphoid infiltrates. And so we've been doing that in these patient cohorts to really look at the interactions of all these factors with molecular features. And this is just, we did whole exomes on the nurses' health study participants developing colon cancer. This is really just the panoply of mutations we found in the whole exome data on their tumors. And we found, actually, as part of it, we found an important mutation, RNF43, which is targetable, and we have a clinical trial looking at a drug targeting that effect. We also looked at the immune infiltrates in the tumors. And this is work we now did, we started about a decade ago, finding that with higher, and forgive me for the slide, but with higher lymphocytic score, higher infiltration of the tumor, there is a diminishing risk of mortality, which has now been shown in many settings, that is, lymphoid infiltrates predict a better outcome for patients. And that we also find that what's driving that lymphoid infiltrate is increasing mutations in the tumors. With increasing mutations is an increasing number of neoantigens produced by those mutations. And then, in fact, what we see is that with increasing neoantigens, there is an increasing likelihood of having lymphocytes in your tumor. And moreover, higher neoantigen scores in your tumors also predict a better outcome. We predict potentially through an inherent lymphoid response, a T-cell response to those tumors, which is really the basis, you know, of why PD-1 antibodies are used. Now, in fact, in colon cancer, these drugs only principally work in patients who have high mutation rates. Those with low mutation rates in colon cancer don't respond to them. And that population of colon cancer patients are patients with mismatch repair or microsatellite high, MSI high tumors. So we actually, in our cohort, tried to look at the mutations in both microsatellite stable, MSS, on the x-axis, and microsatellite high, MSI high patients. And what we find is that in the microsatellite stable patients, we see in the blue mutations mostly in the Wnt signaling pathway. But interestingly, in the MSI high patients, who tend to get lots of lymphocytes in their tumors because of the mutations, they get not only Wnt signaling pathway in blue, they get a lot of immune pathway mutations in the red. And why is that relevant? Because if you look in those MSI high patients, those mutations tend to be mutations that derail antigen-presenting machinery. So that, in fact, it's almost an acquired mechanism that these tumors have a survival effect to try to hide from the immune system, is they actually eliminate things like beta-2 microglobulin, other components that are important to antigen presentation. At the time that patients are diagnosed with MSI-high tumors, who in theory are eligible for checkpoint inhibitors, 25% of them already have a mutation in their antigen-presenting machinery, which is likely going to make them resistant to those drugs. What else is driving an immune response? Well, I mentioned Wnt signaling pathway is operant. We actually find that with increasing activation of the Wnt signaling pathway, there is a diminishing T cell response. We also find that activation of the MAP kinase pathway, most principally through RAS and RAF mutations, very common in colon cancer, that seems to drive down the immune response. And in fact, this is work with Kurt Chalper, if you take a patient with either a RAS or RAF mutation in colon cancer and you give them a MEK inhibitor or a similar type of inhibitor, you actually increase the immune infiltrate. So potentially these pathways are operant to how we can generate immune responses in patients. And then finally, really a growing area of research that we're also trying to leverage is work on the microbiome, right? Really an important area of research across multiple diseases. We've been looking at the microbiome in the tumors of our cohort members. And one tumor that we find, one bacteria we find in the tumors with some regularity is Fusobacterium. We actually find it inside the tumor cells. And we wondered whether Fusobacterium might be driving colon cancer. Why is it in these about 10 to 15% of colon cancers? So in concert with a number of our colleagues, we actually did an intervention in mice that were genetically engineered to get colon cancer, and fed them either a sham, a component of Streptococcus, or Fusobacterium. And if you feed mice, APC mice, Fusobacterium, they get a lot more tumors. Moreover, they get a lot more myeloid-derived suppressor cells in their tumors. And I think this is relevant because there is a growing body of evidence suggesting that your microbiome actually predicts response to PD-1 antibodies. It drives your immune response. So maybe this element of Fusobacterium is important. We actually then looked at whether Fusobacterium presence predicted outcome, and in the red, those with high levels of Fusobacterium in their tumors seem to have a worse survival. They also appear to have a significantly less likely to have immune cells in their tumors. The presence of Fusobacterium seems to inhibit an immune response. And then lastly, we actually looked at mice with colon cancer who had either Fusobacterium or not, and looked to see what happens if you give them a standard antibiotic, and find that with the mice with Fusobacterium on the right, if you give them metronidazole flagyl, they actually have a lower proliferation rate of their tumors, whereas you don't see that in the mice who don't have Fusobacterium in their tumors. So potentially an opportunity to further intervene in the outcome. So, you know, I've had the privilege of working with a variety of very talented people to do this work. I think some of it hopefully informs the way we approach colon cancer, and I appreciate the opportunity to speak with you today, and happy to answer any questions.